All right, welcome everyone to April's Wisconsin Coalition for Social Connection Network meeting. Thanks for being here. We are going to get started with just a round of introductions. So if you want to put this in the chat, your name, your organization, if you're here as part of an organization, and a little icebreaker question, what are you planting this year if you have a green thumb? And if not, what seasonal food are you looking forward to eating? So I'll go ahead and introduce myself. If you don't know me, I am Suzanne Morley. I'm a health promotion program coordinator with the Wisconsin Institute for Healthy Aging, and I coordinate the Wisconsin Coalition for Social Connection. I'm looking forward to planting peas this year. We'll see how it goes. I don't really have that much of a green thumb, but my son has a book about planting different things in a garden, and he has been really interested in planting peas. So we're going to try it out this year. I'm going to look at the chat and see what everyone else is doing. So lots of veggies, it looks like. Looking forward to eating local strawberries. I'm with you on that one. And one tomato plant. Yep. Let us know how that goes. Again, looking forward to fresh strawberries, sweet corn, planting cherry tomatoes, planting a veggie garden, tomatoes, peppers, flowers, sweet peppers. Ooh, raspberries. That's one thing I've always wanted to do. We had a raspberry bush growing up. That sounds fantastic. Fresh garden tomatoes, herbs. Lots of tomatoes in the chat. Strawberries, cucumbers. Making salsa with tomatoes. Spinach. That is one thing I've had success with, is spinach. Flower garden, fruit trees. Wow, it looks like lots of people growing things on their own in their own gardens, which is fantastic. All right, we'll keep throwing those in the chat and we will move on to introduce the agenda and our speakers for today. So we do have two speakers. We're going to focus on older adult mental health and suicide, also for people with disabilities as well with our first speaker. We'll go into some Q&A, so feel free to throw questions in the chat throughout, but we do have some time for Q&A towards the end after our speakers. I'll go into some coalition updates, and then hopefully we'll have some time for some local updates too. So any events that you guys have going on, activities that you want to share, or questions for anyone on the call, and then we'll wrap up. So with that, I'm going to pass it over to Kelsey, our first speaker. And Kelsey is going to talk about Wisconsin's suicide prevention plan and suicide among older adults and people with disabilities. So Kelsey, I am going to turn it over to you.
Thank you. Pull up my slides. All right. All right. Thanks, Suzanne. I'm Kelsey Van Horn, and I'm the Zero Suicide Program Coordinator at Mental Health America of Wisconsin. And along with coordinating our annual virtual Zero Suicide training, I also work on all of our other suicide prevention programming, which I'll talk about some of those projects and programs we have going on in a few minutes. So I would just like to start out with talking about best practice language to use when we talk about suicide and mental health, since both topics carry a lot of stigma and judgment around them. And I'm not here to police anyone, but we just want to keep in mind it's best practice to say died by suicide or suicide death rather than committed suicide, suicide attempt rather than failed or unsuccessful attempt. And then when we're talking about data and trends, we want to use straightforward terms like increasing or rising instead of like skyrocketing or epidemic. And I just also want to address off the top that suicide is a serious public health issue, and there are many factors that contribute to it across the 4 levels of the social ecological model, which is here on the slide, including individual, relationship, community, and societal risk factors. And at MHA, we really focus on the social determinants of health to prevent suicide rather than just looking at it as a mental health issue. And a few risk factors specifically for older adults that are not a mental highlight real quick could be chronic pain or declining physical health, grief and loss from experiencing more deaths as they grow older. Retirement, when a person stops working, their job a lot of times will provide them with a lot of fulfillment and make them feel like a productive member of society. So not working can be difficult. Financial difficulties, and with that can come food or housing instability, loneliness, and social isolation. Those are just a few, not by any means all the risk factors for suicide, but just a few I wanted to mention. And I also just want us to make sure we understand suicide is preventable. And so hopefully today you'll come away with a few resources or a few ideas on ways we can prevent suicide for older adults and individuals with disabilities. So in addition to working on programs at MHA for suicide prevention, I also help coordinate Prevent Suicide Wisconsin, or PSW, which is our statewide public-private partnership. Um, and the mission is to try and reduce the number of people in Wisconsin who either die by suicide or attempt suicide. PSW is a statewide also coalition to raise the visibility of our suicide prevention efforts in the state, and the PSW steering committee provides our leadership structure for that coalition and help us advance our prevention strategies. And MHA, in our role as grantees from DHS, we coordinate and convene PSW activities, including the coalition meetings, steering committee meetings, and we also act as the state designated coordinator for suicide prevention. Another big project we do through PSW is we write the Wisconsin Suicide Prevention Plan, which is a statewide plan that is released every 5 years. And the current plan right now is titled Suicide in Wisconsin Impact and Response Report, which is linked here on the slide, and it was published in 2020. And the plan includes data on suicide deaths and also 4 broad strategies for preventing suicide. And those are increase and enhance protective factors, increase access to care for at-risk populations, implement best practices for prevention in healthcare systems, and then improve surveillance, sorry, can't say the word today, of suicide and evaluation of prevention programs. So improving data around suicide and evaluation. And we're currently in the process of writing the next state plan, which is scheduled to be published and released in September of 2025. So be on the lookout for that. In addition, we also have a website that's linked here, preventsuicide.wi.org, where we have a lot of different resources, data, reports, trainings, and events happening across the state in suicide prevention. We host 2 general coalition meetings, as I said before. These are virtual meetings. They're open to anyone who's interested in learning about suicide prevention or networking, sharing resources, and all of that. So anyone is welcome to come to those, and I have the dates listed on the last slide. So if you're interested, also sign up for our e-newsletter. We send out a monthly newsletter, sometimes a little more frequently than monthly if we have a lot of events going on, but we share resources and trainings happening in the state. Also share information about our coalition meetings and our conference, which is coming up. All right. There we go. We also hold an annual conference every year, and registration for our conference now is open. This year, our conference will be in person on Tuesday, May 13th in Milwaukee at Thrive on King. That's our pre-conference day. We'll be having time for networking and resource tables. We'll also have a presentation from AFSP researcher, and they'll be presenting on suicide risks during employment and housing transitions in mid and late life, which will be really interesting. And then we're also going to have a faith-based suicide prevention panel discussion that day. And then our virtual conference days are Wednesday, May 14th to Friday, May 16th. Those will be held over Zoom from 8 till about 1:15 each of the 3 days. And we have 2 keynote presenters scheduled. One is Dr. Joyce Chu. She created the cultural theory and model of suicide. And the other is Dr. Leah Knox. She created Black Space in Milwaukee, along with many other things. And then on Friday, we always end the conference with a lived experience panel, which is always the highlight of the conference for everyone. So I encourage you to register. And yes, I will provide these slides for anyone if they would like. But yeah, go to this link on the slide. We have the agenda listed for the conference and all the registration information. Okay, so now we're gonna jump into looking at the data for suicide deaths in Wisconsin. DHS does provide a state suicide data dashboard that I've linked here, which is a great resource, and it provides data, recent data from death records for Wisconsin residents, and then the Wisconsin Violent Death Reporting System, which includes information from coroners and medical examiners, and some law enforcement reports. I will say up front though, Wisconsin and nationally, we are lacking data on suicides for individuals with disabilities. This information will most likely be collected and found on suicide death reviews. Unfortunately, right now, not every county in Wisconsin has a death review or suicide death review team, and there's no standardization of that information, and it's not shared with the public. But the dashboard does include a lot of great information on trends for suicides in older adults in the state, and it lists data by age, race and ethnicity and sex, veteran status, method of suicide, if there are any mental health concerns or treatment, a history of suicidal thoughts or attempts, and then a few other problems that may have contributed to the death. So I'm just going to highlight a few data trends that were found for older adults in Wisconsin in 2022, which is the most recent data on the dashboard. But I encourage you to check out the dashboard and look at all the data that's available there in your free time if you're interested. So when we look at the suicide rate by age group and sex, the highest suicide death rate for men was for the age group 75 plus. It was 48.7 per 100,000. The second highest death rate for males was ages 25 to 34, and that was 39.2 per 100,000. For females ages 65 to 74, the death rate was 6.2 per 100,000, which is the fifth highest for the age groups for females. And thankfully, the females 75 plus, there were too few suicide deaths, so they didn't list a rate for that age group. And then just looking at method of suicide death for adults 55 plus, 63% use firearms, which was the highest of the three age groups they have listed on the dashboard, and 17.7% died by poisoning, which was also the highest for that of those three age groups. Some other problems that contributed to the suicide death for adults 55 plus, 51% had a physical health problem, which was the highest of the three age groups. 12% had an intimate partner problem, and 8.9% had a financial problem. And then 7.2% had a job or employment problem. And then looking at mental health concerns for adults 55 plus, 47.3% had a current mental health concern. 21.8% were receiving mental health treatment. 20.9% had a current alcohol use concern, and then 8.3% had a substance use concern. And then I know I said we're lacking data for individuals with disabilities, but there were two national studies I wanted to highlight quick on suicide thoughts and mental distress. So the first was a 2021 survey, and they found that adults with disabilities were 3 times more likely to report suicidal ideation in the past month compared to people without disabilities. So yes, it was 30.6% versus 8.3%. And then another previous study, I believe this one was in 2019, reported individuals with disabilities were 4.6 times higher to have reported mental distress, which can be a risk factor for suicide. So 32.9% of individuals with disabilities reported a mental distress compared to 7.2% of the general population. So I think this just emphasizes the need for more and better data collection for this group of individuals. And then I just wanted to highlight a few national resources that could be used to help prevent suicide for older adults. The Suicide Prevention Resource Center, SPRC, They're funded by SAMHSA, and they're the primary national resource center devoted to preventing suicides and implementing the National Strategy for Suicide Prevention, which was released in the spring of 2024. And so I've linked a few reports from their website. I've linked the national strategy here if you're interested in reading that. It's a very long, comprehensive plan for preventing suicide in the country. Um, Two reports on preventing suicide among older adults and reducing loneliness and social isolation. Two toolkits here that can be used for people working in senior centers or senior living communities, and then another resource for professionals working in senior living communities. And then a few resources for individuals with disabilities. 988, which is the National Suicide Crisis Lifeline. It's available 24/7. They provide services for people who are deaf, hard of hearing, or experiencing hearing loss. So you can find information on that resource, the link here on the slide. The Foundation for Epilepsy provides a lot of information and resources on suicide prevention at this link, and they also have a helpline. Um, excuse me, the number is 800-332-1000. And then finally, I included this study that was done in Denmark, and it found that people who had autism spectrum disorder were 4 times more likely to die by suicide than individuals without an autism diagnosis. All right, and then I just wanted to mention a few of the prevention strategies from the state plan that I think could help prevent suicides for older adults and individuals with disabilities. So the first from strategy 1, which was increase and enhance protective factors, is to promote healthy communities by increasing social connectedness. Your group is already working on this prevention goal a lot, so I'm not going to spend a lot of time on it, but I did want to point out that it is a state priority for us for suicide prevention, and it will be included again in our list of prevention goals for the 2025 state plan. The next objective from strategy 1 I wanted to highlight is increasing safety with lethal means, and temporary removing access to lethal means when someone's experiencing thoughts of suicide may interrupt an attempt or make it less lethal, and that provides more time for intervention. And research has shown that most people, about 90%, who survive a suicide attempt do not die by suicide, and about 70% of people who survive an attempt never reattempt. So that just emphasizes the importance of the need for family, friends, and healthcare providers to talk about lethal means, including firearms and safe storage, with older adults or anyone that is at risk of suicide or experiencing suicide risk factors. Especially since adults 55 plus in Wisconsin, 63% of them that died by suicide used a firearm. So a few resources in Wisconsin for reducing access to lethal means. I linked first, Live Today, Put It Away. This is a gunshot project in Wisconsin through the John D. Mason Program for Veterans, and their website shows a map of the state and different firearm retailers or ranges and law enforcement departments that will provide anyone with temporary safe storage for their firearms at little to no cost if they are at risk of suicide or feeling like they're experiencing a crisis and do not want to have those around them. The next is counseling on access to lethal means training or CALM trainings. I linked a free online course here, and these trainings cover how to identify who might benefit from lethal means counseling, ask about their access to lethal means, and then work with them or their families to reduce access and have a plan, a safety plan. This course is primarily for mental health professionals, but anyone that works with people at risk of suicide would really benefit from it. And then the last two resources are a safe disposal for non-pharmaceutical waste from the DNR, and then a MedDrop program in Dane County through Safe Communities. The next strategy I want to talk about quick is increase access to care for at-risk populations and support innovative ways to expand access to behavioral health services. And this can be done through technologies like telehealth or peer-led or non-clinical support services. And services provided by certified peer specialists. They share the same life experience of either a mental health or substance use issue, and some of them may have experienced suicidal thoughts or behavior as well. And as peer support, they can develop trust with individuals experiencing similar challenges. They can provide a non-judgmental, safe space to talk about these issues, give encouragement, share resources, and also just support people. So a few resources we have through MHA that are our peer-led resources. Unfortunately, our statewide Warm Line Uplift just lost its funding a week or two ago through the federal cuts. So that was sad to see, but we still have the R&R House, which is the nation's first peer-run respite for veterans. And any Wisconsin veteran can go to the R&R House and receive support from a veteran peer support specialist in a residential setting, and they can stay for up to 7 days at the house free of charge. And they also offer a veteran peer support warm line. The number is 262-336-9540, which you can also find at the link on the slide. And then we do offer two virtual suicide support groups. The first one is Alternatives to Suicide, and this is a peer-led support group for people with lived experience of suicidal thoughts or attempts. And it allows them a safe space to talk about their suicidal thoughts or feelings and experiences without the fear of being judged or having 911 called on them. And then the next one is Survivors Helping Survivors. This is a virtual peer-led support group for people who've lost a loved one to suicide. And then I also included a link for a list of peer-run respites in Wisconsin that's provided through DHS. And then strategy 3, implement practices for prevention in healthcare systems. And one objective is to promote a zero suicide approach. And we do, as my title, I help coordinate our zero suicide training through MHA. Our applications are still open. We just extended the deadline to next Friday, yeah, April 25th. You can find out more information here at this link. This training is for health and behavioral health organizations that provide direct client care. Oops, sorry. And the framework is a system-wide organizational commitment to safer suicide care. It's grounded in the most current systematic and evidence-based research in suicide prevention. A few of the concepts for this training and framework include the aspirational goal of zero suicide deaths, since we believe suicide is preventable, a fundamental shift away from accepting suicide as a consequence of mental illness to understanding it's preventable again, focus on system-wide quality improvement rather than blaming individuals when there is a suicide attempt or death, an emphasis on improving systems and developing policies and procedures instead of relying on individuals. And then, yeah, just a system-wide commitment to continue to implement and try to provide safer suicide care. And then the last strategy I wanted to emphasize was improved data surveillance of suicide, especially improving the data collection for suicide deaths for individuals with disabilities, since that is an issue in Wisconsin and nationwide. And a few opportunities for action for this objective that we list in the state plan. One is share information from suicide death review teams across the state into a unified database that could be accessed by the public. Some stakeholders that could help with this are county suicide death review teams, the Medical College of Wisconsin, Wisconsin DHS, the Department of Justice, and Children's Health Alliance of Wisconsin. And then also link data from multiple sources with the Wisconsin Violent Death Reporting System for a more comprehensive review of suicide deaths and self-harm injuries. And that's it. Thank you. I know I gave you a lot of information. I hope you found some of it helpful. But I encourage you to reach out to me if you ever have questions about suicides in Wisconsin or any of our programs. Our next PSW General Coalition meeting is Thursday, June 12th from noon to 1:30. And if you sign up for our newsletter, you'll get updates on these meetings and the conference and other resources we provide throughout the state. So thank you.
And thank you, Kelsey, for sharing all that information. I know there's tons of resources available, which is great. I know it can be kind of shocking to see that data as well related to older adults. So that's why we thought it would be important to talk about this, especially with Mental Health Awareness Month coming up next month. So thanks again for sharing all that. And I know there's just some questions about sharing the slides and all those links that were provided. So those will be shared after the meeting today. So I'm going to turn it over now to Dr. Rebecca, who's going to share about the Wisconsin STAR method and things that can impact an older adult's mental health. So Rebecca, you can take it away.
All right, thank you so much. And thanks so much for having me. I'm a geriatric psychiatrist by training, and my current work is in Jefferson and Dodge counties. And I'm going to just be talking about the Wisconsin STAR method and just a little bit about the importance of social connection for the well-being of older adults. Let me see here. Okay, so I have no financial disclosures. I'm not going to be discussing off-label medication use. Most of my slides are adapted from Dr. Tim Howell's work, and so I just want to give credit and thanks to him. He's the creator of the Wisconsin STAR method, as we'll talk about, and any images are from the public domain and not copyrighted. So talking about the Wisconsin STAR method, this is just a graphic to show what the method looks like. And we'll definitely talk more about it, but you can see it's a star, a five-sided star, where the center is talking about a symptom or a problem. And then we have all these different factors around the arms of the star. So this method was developed by Dr. Tim Howell, who is a now retired UW geriatric psychiatrist, one of my mentors. And he developed this out of network theory. And it's this holistic model and basically designed to help us kind of organize and conceptualize a question, a problem, a symptom. And it's not just talking, where I've used it most often has been talking about an individual person or patient and their situation and something we're trying to problem solve. But it can also be used to tackle systemic problems as well, and can also be used to help us assemble teams, can help us kind of conceptualize normal aging, a variety of things that it can be used for. And it's designed to be utilized by interdisciplinary teams. So where I used it the most was my first job out of fellowship was at the Veterans Hospital in Madison, and I worked in the Geriatric Research Education and Clinical Center on an interdisciplinary team that had social work and geriatric psychiatry, geriatric medicine, psychology, neuropsychology, and anyway, we were providing care in a consultative model, and we would talk about individual cases, and we'd use this Wisconsin STAR method to be able to do that. So I think it's just a beautiful way to kind of bring a team together and get everyone's perspectives. So as we talked about, there's sort of these 5 domains or arms of the star that surround the center. And at the center, you put the symptom, problem, question, whatever you're trying to address. Each arm represents a facet or category, and we'll talk more about that. And details can be filled in around each arm. When we would be doing this, we'd be actually doing it on a whiteboard. So we draw a star, and kind of put it all out there so that we could just see it as this two-dimensional model that kind of served as our working memory as we're talking about, a challenging situation or case. And the end result is this kind of beautiful representation of the unique situation of the person or their problem. And it's really kind of, looking at the ecology of the situation. And it's a great way to organize information and try to be able to problem solve. So looking just a little more in depth at the method. So you can see the star here, and at the top, we'll start at the top arm, we have medication factors. So this is kind of, not just listing all the medications, but also sort of considering how folks are doing in terms of adherence, how folks are doing if they are, borrowing meds from a family member or using meds inappropriately, and then what's being taken over the counter in terms of supplements, things like that. Next, we have medical factors kind of moving around clockwise, diagnoses, symptoms, physical challenges, mobility issues, all of that. And then next we have, he conceptualizes the behavioral factors, but could be mental health, could be whatever your preferred language may be. And Dr. Howell utilizes this acronym COMPASS to kind of capture all of the various potential factors. So we have cognition, so talking about, for C, talking about dementia, delirium, mild cognitive impairment, concerns like that. Then we have organic, which kind of gets back to the medical factors. We have mood, psychotic symptoms, so delusions, hallucinations. We have anxiety, we have substance use in this section as well. Somatization, which would be sort of physical manifestation of stress or, mental health concerns, and then sleep. And so that's a great way to kind of capture everything. Next, I'm going to go to the personal arm of the star, which actually has its own star. So I will just bring that up here and then I'll go back to the previous slide. It's really beautiful to learn from Dr. Howell about the importance of the personal arm of the star, really getting to know someone and kind of how they operate, what's important to them. You can see, first of all, rules of thumb. So like how would somebody solve a problem or act in a certain situation, based on what's important to them and kind of how they operate, and based on their culture as well. Next is loyalties. Who are they loyal to? What's most important to them? Then values, personality traits. Certainly if we're conceptualizing a difficult case, a lot of our consults were, talking about cognitive impairment. Had personality changed? That was always a question. And then finally, situation awareness. So knowledge and experiences, maybe trauma-informed care kind of coming in there, thinking about what someone's experiences have been in life, that color how they respond to situations and what's important to them. And then finally, going back to social factors, the social arm of the star, talking about all the good things that make up a social history, family situation, finances, housing, transportation, community support, and neighborhood environment, kind of what their living environment looks like. And then legal questions, is there a surrogate decision maker, or just somebody has APS been contacted for some reason, concern of self-neglect or elder abuse, that sort of thing. So we'll go ahead and go to a case. I thought we could do a case and just kind of illustrate how this method can be so helpful. So this is a case from Dr. Howell, 73-year-old retired truck driver. You can see the medical factors on the left-hand side over here. And so this person is dealing with a number of challenges: Parkinson's disease, arthritis, recurrent falls, dealing with some weakness. And then, of course, with a lot of quality of life concerns potentially with urinary incontinence, medication factors kind of moving over there. We see that he is on Sinemet or carbidopa-levodopa for his Parkinson's. He also takes some ibuprofen, wondering how effective that is for pain and if that might also be causing issues like gastritis or renal impairment. He's on oxybutynin, which is medication to help with the urinary incontinence, but how much is it helping and can come with a number of side effects. And then we have an over-the-counter sleep aid, which is generally diphenhydramine or Benadryl, which we try to avoid in folks who are better than 60. So there's that as well. Then we have behavioral factors. So this gentleman is dealing with some concerns about cognitive impairment, and he's having some trouble managing his affairs. He's more irritable, and he's also missing a number of medications per week, a number of doses, and he's not wanting to use his walker. He just doesn't want to do that. Then in terms of social factors, he's become more withdrawn. He's not as engaged. He's only marginal at managing his finances right now. And then a huge stressor, his spouse is living with cancer, colon cancer, and they have an older daughter who's nearby. They have other children as well, but the oldest daughter's closest, and she's just feeling really helpless, feeling really stressed, trying to manage everything for her parents. So this is a really complex case, and we haven't even gotten to the personal arm of the star yet, but you can see, I mean, 7 medical problems, 7 medications, oftentimes there's even more, 22 plus potentially interacting variables so far with what we've talked about. So how would we even approach this? Where would we start? And the star will show you when we get to the solutions portion of the star. That can be a really helpful way to organize all of this and kind of come up with some areas for intervention. So going to the personal arm of the star for this gentleman, he's really worried about his appearance. And I hear this from a number of my I heard it a lot from my older male veterans that I worked with. I don't want to look old. I don't want to use that walker. And I heard that quite a bit. I don't want to use the walker. I don't want to use the cane. So that's kind of where that's coming from. He's always had very high expectations of himself and others. He's coped through being busy, very much an action-focused coping person who tends to do action-focused coping, and values being productive. And as you can imagine, kind of with the Parkinson's, with having more mobility issues, that has been really challenging for him. He's also very loyal to his family, really identifies as the patriarch, but as a provider, that's kind of how his self-esteem has been met, is providing for the family. And he's starting to feel like with this role transition, like that's less, like he's contributing less, which we know is not true, but that's how he's feeling. So here's just everything laid out around the star that we've all talked about. So I won't spend a ton of time on this slide, but I'll go to the next one where we can kind of talk about how to approach looking at all of this and coming up with some potential areas for intervention. So starting at the top, we can go with medication factors and then kind of work clockwise. So looking at the oxybutynin, it turns out that it's really just not that effective for his urinary incontinence. It's probably just causing more side effects than good. So should that be discontinued? Looking at the ibuprofen and jumping over to medical factors with his arthritis, it's not adequately controlling his pain. So is there something we could do differently for his pain? And then talking about that over-the-counter sleeping pill, certainly highly anticholinergic diphenhydramine is highly anticholinergic and can cause a lot of negative side effects for folks who are better than 60, 65. So, not recommending that and maybe trying to come up with some other solution to help with sleep. And as we look more at medical factors, looking at the falls and weakness and the Parkinson's, could we encourage some kind of, I know a lot of gyms or a lot of health systems will have, Parkinson's specific or movement disorder specific exercise classes and things that folks can do. Is that something he could do? Could he do PT? Would that be helpful if he could do physical therapy? Of course, getting to the appointments might be a challenge, but could we do home PT? Could we bring somebody into the home to help with that? And then looking at the behavioral factors. So he's more irritable. He's got this concern for cognitive impairment. Is the cognitive impairment, is there actually kind of an early process going on here? Or, like an MCI or even an early dementia? Or is this more pseudo dementia, which is kind of what we conceptualize as the cognitive impairment that can come with a depression, especially later in life? Is he depressed? Is there something going on there? And then about the refusal to use a walker, kind of talking about that, problem solving that, what's that all about? So next, moving over to the personal factors, his worry about appearance, his high expectations, coping by being busy, valuing productivity. Could we do some kind of like an occupational therapy assessment to look at what he still can do, what his strengths are, and then what areas can we help him more with? And would he ever consider, this can be a hard sell, but would he ever consider, some psychotherapy to focus on adapting to these changes that he's dealing with, and also, of course, the stress of dealing with a spouse with cancer. And then finally, moving over to social factors. talking about, how long has his wife been dealing with this? Can we mobilize folks again? A lot of times early on with a cancer diagnosis, there's, a lot of casseroles that show up, but once things progress and you've been in treatment for a while, those resources can kind of dwindle. The visits kind of can taper off. And so I think remobilizing the family and friends and supports and seeing if we can get folks in. And then as far as the finances go, is there some way to get family to help, and hopefully not the oldest daughter, hopefully, another family member might be able to help with the finances, since she has so much going on, or perhaps she really wants to, and it makes the most sense for her to be helping with that right now. And then as far as the social isolation goes, is there maybe like a volunteer friendly visitor program or something where someone could come in and visit with him? So lots of potential solutions, and this is just a great method for kind of laying everything out, and then we can brainstorm as a team, kind of what might be most helpful. So, why use the Wisconsin Star method? I mean, I hope it's kind of self-explanatory, but in working with older adults and folks with disabilities, a lot of times things get really complex, right? Multiple simultaneous problems interacting with each other, atypical or unusual problems changing over time, and we have really scarce resources, and our resources, unfortunately, are becoming a bit scarcer. We have less time, staff, finances, and so this is a really great way to kind of lay everything out in a 2D way, so that we can all be on the same page as a team. So I just want to show a couple more stars just really quickly. I know we have limited time. I'm actually going to go ahead and move on from these stars, but you will have these slides. This is just a way to consider who might be best on a team to try and solve a problem. This is a way to conceptualize a systemic problem and who you could harness to help solve a systemic problem. This is a normal aging star, so looking at what all makes up the changes that we expect, the transitions we expect with normal aging in each of the domains. And so I briefly just wanted to talk about the importance of social connection for older adult well-being. So we know loneliness and social isolation aren't one and the same, but they absolutely influence each other. We know from research studies that loneliness actually peaks in middle age. So as older adults age, they are less likely to become or to be lonely or report feeling lonely. But we know that social isolation and loneliness have negative health sequelae. They actually can rival smoking in terms of mortality. And so we know that this is a big deal. We also know that the reverse is true. So folks who have better social connection have increased survival. They're better able to tolerate stress and illness. And certain health and lifestyle factors are associated with decreased loneliness. I mean, some of these are kind of self-explanatory, but things like folks who sleep better report being less lonely. Folks who exercise regularly report being less lonely. Folks who are sexually active, folks who are involved in some kind of religious community report being less lonely. Folks who have neighbors or live in a community where they know their neighbors. And then folks who do volunteer work. And so the thing is, all of this is wonderful and true. We know all of this. There's been some study of potential interventions, and unfortunately, the data is not somewhat limited. There have been a number of studies that have been kind of equivocal or even negative. And I think that really what this speaks to, because most of the data we have that's positive is actually coming out of long-term care. So when we're talking about community dwelling older adults, there's so many variables that can't be controlled for in these studies. And so when you have folks in long-term care, a lot of those variables are removed, or a number of those variables are removed. And so the best data we have is looking at long-term care settings, and it's looking at animal therapy. So actually bringing in therapy animals at reducing loneliness. That was positive, or has been positive in a number of studies. And then technological interventions. So things like bringing in the opportunity to connect on social media, or bringing in like video visitors, having an app where folks can connect. Things like that have actually been shown to be positive. So we know that social connectedness predicts better outcomes for older adults. The older adults that I'm seeing are folks who are living with mental illness. And I just want to emphasize it's not just it's not just family. The longer that we're privileged to live, the more grief and loss we accumulate. But chosen family, friends, community, neighbors, just to highlight, I was just visiting with someone the other day who's in a long-term care setting, and they have just blossomed socially. They have just this beautiful network of friends that they've met in their long-term care community, and it's been beautiful. Whereas when I was taking care of my grandparents, they ended up in long-term care, and they just wanted each other. That's all they wanted. They didn't socialize with anyone. They just stayed in their room, just the two of them, but that was enough for them. And so I think that, we're all unique individuals, and older adults are all unique individuals, and they're going to want different things. Um, so as a geriatric psychiatrist, I see a lot of, my sample is skewed in terms of what I'm seeing. I'm not seeing, just the average older adult. And so it's important for me to remember that my sample is biased. But I see a number of unbefriended older adults. That's a term that I think is used with some regularity. And these folks almost always have a harder time. Um, and so just social connection is so important for older adult well-being. So thank you so much for having me. I really appreciate it. I apologize. I know I went over a minute, but I appreciate it. Thank you so much.
Thank you, Rebecca. I really appreciated seeing your case study. I think it kind of goes to show we are so much more than just, on the surface. There's so many other things like that individuals, Parkinson's and urinary incontinence and falls that can all contribute to, their social isolation and loneliness. But then there's many other opportunities to get them connected too. So thank you for sharing that. There is a question on the chat. What advice do you have for supporting individuals who have many indicators but are resistant to accepting support?
Yeah, that is a great question, and that can be so tough. I think, just trying to walk the journey with them as much as I can, just be there. Be there and continue offering support and continue checking in. I know, this just brought to mind like this in Dane County, there's kind of this friendly EMS visitor program for folks who are at risk, who have a lot of EMS visits, like emergency medical calls. And it's designed to kind of get people into treatment and care. And so just thinking about like just trying to harness as many resources as we can for folks and just really be there as much as we can. And sometimes, unfortunately, in my world, sometimes it's kind of until we get to a tipping point of like, oh my goodness, this is self-neglect. We've got to get, APS involved. Sometimes it gets to that point, but I think for so many people, it doesn't get to that point, and it's like we just kind of have to walk the journey with them and just offer support as much as we can.
Thank you. Kelsey, anything that you want to add to that for people that are resistant to accepting support?
No, I think Rebecca said, yeah, great. I mean, you can offer as much as possible and just let them know you're there. I think, yeah, reassuring.
Awesome. Yeah, thank you both. If there are any other questions, I'll just leave a brief space for that now. Otherwise, thank you, Rebecca. Thank you, Kelsey, for sharing all the great information related to mental health and, suicide risk and the Wisconsin STAR method for older adults and people with disabilities. Again, the slides will be shared in the post meeting emails. I'm going to go and move on now to a few coalition updates. So kind of along the same topic, like I said, we are doing a consumer webinar for Mental Health Awareness Month next month in May. So it's on May 20th. We'll have Rebecca back with us for that talk. And then we'll also have someone from the Division of Extension sharing about one of their programs for older adults, and then someone from the 988 Wisconsin Lifeline sharing about that resource that's available as well. So we have the link in the slide. If you want to share the flyer, you can download that and encourage older adults in your communities to attend this webinar. Few other things. We have a Global Loneliness Awareness Week coming up in June, which somehow is just a couple months away. This is a movement kind of led out of the UK, but celebrated globally. And the theme this year is meeting loneliness together. So there's a website that I'll share in the post meeting email where you can click on this button and generate connection ideas. But we really wanted to kind of hear from you all, and we have a survey that I'll share after this meeting. And if you could share with us one way that your organization or community is going to meet loneliness together during Global Loneliness Awareness Week. So whether that is, expressing gratitude at your local senior center to the participants, or scheduling some sort of an event. It can be something simple, or you can do something bigger like a social connection related event, but sharing with the coalition what you're doing, and then we will plan to share out all of the things that are shared with us so that everyone throughout the state that's in the network can kind of see the different activities that people are planning on doing during this week. Last update for the coalition before I'll turn it over to all of you for updates. We are doing a network engagement survey, so we really want to hear from you about your engagement and participation in our network. So after the Zoom webinar closes today, you'll actually be automatically redirected to a survey to complete. It is fairly short. It's about 12 questions or so, but you can see just a screenshot on the screen. The questions are fairly short and easy to respond to. Just kind of wanting to learn more about the people that are attending our network meetings, and all of the things that feedback can provide for us, and we can adapt and take into consideration for future events and future coalition activities. So again, that'll be automatically in your browser after we close out of the webinar today. But then I'll also share a link in the post-webinar email that you can fill it out there too. So with that, we do have about 8 minutes or so. So I wanted to save a little space here for any local updates. So if you have any upcoming events or any questions, challenges, successes, or resources to share related to reducing social isolation and loneliness and increasing connections for older adults and people with disabilities, wanted to leave some space for that. So feel free to either drop it in the chat or you can come off of mute. So I'm going to stop talking now and leave some time for everyone to do that. Not seeing anything yet, but there's definitely got to be something going on within the next couple months that y'all are doing that can, whether it's events or a question that you have. See in the chat, I would love added ideas for this topic, as I'm in a New Bridge of Madison coalition that started this year. So Amy dropped her contact info in the chat. So if anyone has any ideas, definitely reach out to Amy. I know this is the first time I kind of left it open a little bit at the end of the meeting. So maybe next meeting, I'll prep you all so you can come prepared to do this. I will just share briefly now. So we do have the Nationwide Network of Champions. The link and QR code for that is on the screen. We have our Wisconsin community on there, our Facebook page. If you haven't liked that, we regularly post on our Facebook. If you have any questions, you can email our email, and then a reminder on upcoming network meetings. Our next one will be in June, the week after Global Loneliness Awareness Week. And the recording for this meeting will be sent out within the next day or two. So again, thank you to our speakers. If you do have anything to share that you want to share with our network, definitely send me an email on that. Again, please complete our network engagement survey and then share out what you and your organization will be doing to meet loneliness together in June for Global Loneliness Awareness Week. Thanks, everyone.